So welcome to everyone. I'm going to pass over the microphone to Vicky, our representative from Uganda. Vicky is going to be facilitating the session for today. So welcome, Vicky.
Good afternoon, everyone. My name is Opia Vicky. I am a palliative care specialist based in Uganda, Adjumani. I am the ED of Peace Hospice Adjumani. I am requesting that, Erin, you can share my slide.
Vicky, today Gladys and Mackuline will be presenting on communication. Did you want to introduce them? They'll be the first ones presenting today.
Okay, thank you so much. Gladys from Kenya Hospice Palliative Care Department. Maybe she can talk a little bit about herself. Gladys, you're welcome.
Hi everyone, my name is Gladys. I am a palliative care nurse specialist. I'm also a psychologist. I work at Kennyatta National Hospital, and I'm here. I'm glad to be here to talk about communication techniques in palliative care. Thank you, Vicky.
Thank you so much, Gladys. I will be happy to hear from you.
Thank you.
Gladys, you have the ability to share your screen for the lecture part of the session today.
Yes, let me share.
Okay, great. And just a reminder for everyone, if you can keep your video on, if your network permits, it's always great to see your faces, regardless of where you're working. It's always nice to see everyone. So you can give a wave. And just a reminder, please stay muted during the session. We will have times for open discussion where we'll ask you to raise your hand and we'll choose you to speak. And don't forget to rename your Zoom ID so we can track the attendance. Gladys, I can see your screen looks really good. If you just want to present on full screen, then we can start for today. Perfect. Welcome, Gladys.
Thank you, Erin. Good afternoon once more, and good morning to those who are in the morning. I'm going to share about communication techniques in palliative care. I'm here with my co-presenter, Mackuline, Atieno, and we are glad to be here today. Just to go straight because of the time, because I know communication is very wide. Just a moment, sorry for that. Just to give my outline of what we are going to learn today, we need to learn about the communication components and the components of effective communication in palliative care. We need to understand the communication difficulties, and we are going to learn communication techniques to handle those difficulties and be aware of the barriers of in communicating with the patients. Just a minute, I'm just setting my screen. It's blocking some information. Sorry for that. Okay. So to introduce my topic, I want to introduce my topic. An effective communication is a core clinical skill. It's not an option and the foundation of excellent palliative care. And one of the elements in communication is truth telling. It's important to know that truth is one of the most powerful therapeutic agents, but we still need to develop a proper understanding of its clinical pharmacology and to recognize its optimal timing and dosage. You don't need to tell the patient everything when they are not ready. We need to know when to tell everything and when not to tell. Communication of painful truth does not equal to distraction of hope. The goals of communication is to share information with the patients, to reduce uncertainty, to build trust between the patient and the caregivers, to explore patients' worries, to help patients make decisions about their care, and also to improve patients and family satisfaction with the care we give. There are some of the basic theories about communication. These are just basic to everyone else. And even when I meet somebody new, you'll agree with me, these are basic. One of the basic theory is to introduce yourself. How frequent do we introduce ourselves to the patients? But as we all know that most of our palliative care patients are weak, are very sick. So we need to do it more frequent, even if you previously introduced yourself to the patient. If you go to the patient after 2 days, introduce yourself again, at least telling the patient, remember me, my name is Gladys, I was here yesterday. Because these patients have their cognitive is not good, they might have forgotten. You may have gone with another hairstyle or another dressing. You address the patient by their name. Don't call them that patient at that corner or that patient with the breast cancer. Establish who the other person is. Most of the time, this is where we make a mistake, because every time we are talking to the patients or they knock to your office and they are a man and a woman, we always assume this is a couple, but that is not the case. Most of the time you hear when we are consulting patients and you are asking them, why can't your husband go and bring this? And they are maybe a sister and a brother. So always established. Could you tell me who is accompanying you? Establish what they already know, because we assume most of the time the patients know everything. They could be going through treatment and they don't know they have this condition. They don't know they have cancer. Use simple language. Avoid medical jargons, because some patients, we tell them very complicated names, like you have carcinoma, you have hepatocellular carcinoma, and they go home thinking it's a very complicated or it's a very beautiful condition. They don't go home thinking they have cancer. Think about how you look yourself, how you appear. Are you looking scary? Are you looking shocked because of the way the patient came in, looking cachectic or looking dirty? How are you looking yourself? Be professional, know your boundaries, where you are supposed to reach and where you are not supposed to reach. Some of the qualities of a good communicator include, at least you need to be knowledgeable, you need to know some facts about what you are going to talk, you need to clear with, to give information which is going to be clear, and you need to be able to keep confidentiality of the patients. For them to give you information, you need to assure them that whatever you are going to talk, it's not going to be for discussion all over. I would feel so bad if I disclose all my history to you and all of a sudden I hear it with my neighbor at home. You need to be sincere, and you need not to be judgmental to patients, and sensitive also. Sensitive in matter that even if they have values which are not aligning with yours, respect their values, especially culture and their values. They may come feeling like, no, we don't cry, and you are here thinking, I think she's too sick, she should be crying. You need to be empathetic. And how do we empathize? Do we empathize, or we just or we sympathize. We need to be good listeners. I want to appreciate that most of the patients come just all the way to be listened to, just to come to hear what we are going to tell them or what they are going to tell, whether we are going to listen to them. And then are we able to pick the nonverbal cues as they speak to us, because that is the key. I'm going to introduce a 6 key point toolkit. This is the toolkit we work with. We are supposed to work with. It is a tool like when you call mechanic to come and repair your car, it comes with a toolkit. So this is a toolkit of communication. And to start with, there is no order of using this toolkit, but the first one I usually say it should be the comfort toolkit. When you are talking to a patient, the patient should be very comfortable. Just throwing a small question like, are you comfortable? That one knocks the patient. That one makes the patient feel, oh, this person is so caring. Question style. The more open the question, the more information you are likely to gather. Questions should be preference with phrases like, please, may I, or could you kindly share with me? Not just telling the patient, tell me what you have been told. No, that one will look like you are interrogating a patient until the patient will look like, I'm at the wrong place. Language is the tool, which at least we are supposed to use the language which is understandable by the patient. If the patient cannot speak your local language and that is what he can speak, you can consult, you can look for somebody else to speak to the patient. You can, if there is no one else who can speak that language, you can look for a translator. And language, I repeat, which has no medical jargons. Reflection is another tool which is very good. You pick key words as the patient share, words associated with the feelings. As they talk, you will realize that the tone is changing. They have anger, they are happy at one point. Are you able to pick those feelings? Summarization is the 5th tool. A fantastic tool if you feel stuck in a consultation like we usually do. Even if you are an expert in communication, sometimes a patient can throw a question on your face and ask you, am I going to die? Or is my mother going to die? And you feel like you are stuck. You can always go back and summarize what the patient has been telling you so that you can start off again. And that is why I'm saying it's the best tool to unstuck you if you feel stuck. Listening is the 6th and the last tool, and not just listening. You need to listen actively, including silence. Actively, you listen together with your feelings, together with your body, because patients, as they talk, you need to feel them. Even if they keep quiet, even if they are decided to not to speak, they are still saying something within themselves. So do not interrupt, continue listening and continue empathizing with them. Listening skill. We have a rule in communication, 80-20 rule, which says we are supposed to listen to the patient 80% of the consultation time and talk only 20%. So the patient is supposed to talk 80%. But this is vice versa, worldwide. Those who are listening from the diaspora, you can attest to me. Most of the time, we are the ones who are talking the 80, even 90%, and we give patients very slim or very few minutes to speak. I have witnessed this when we are going on for medical ward rounds. The patient is asked, do you have pain? And before they respond, another question is shouted, another question, and another question. When are they going to respond to all these multiple questions? 80-20 rule. We need to pay attention to the non-verbal and verbal communication, because the studies show that 7% of the message is verbally communicated by words. 93 is non-verbal. 93 is a very big percentage, which 38% is vocal and 55% is posture and expression, facial expression, as demonstrated by psychologist Albert. Halbert demonstrated this one very clearly. The 7% has feelings and attitude is the nuance that has spoken. Tone is a feeling and attitude in the voice. Even the tone and the way I'm shouting is 38%. Then the 55%, which is the majority, is at the facial expression, posture, and gesture. As the patient demonstrates through the posture and even by showing through the face, we are supposed to pick, could the patient be suffering because of pain and is not talking about it? And then remember the tools to ask the patient, I can see you are not happy on your face. Could you be in pain? Are you comfortable? So the Halbert model, a lesson from the Albert research is that we need to pay attention to far more than just words from our patients. Not just words, don't listen to what they say, but listen, including observing what they are doing. So communication, as I said, is not easy. There are difficulties. And what are these difficulties? One of the difficulties is breaking of bad news. Who is comfortable here telling a patient now, your disease has come back? Or telling a patient, your treatment has changed. We are no longer going to give you active treatment. We are just going to get you. Difficulty in breaking bad news. We have difficulty questions in communication. As you talk, the patient throws a question over you, and you are like, why did she have another difficulty? A valid of which we know very well, it's a valid coping mechanism of those who are unable to cope or not ready to cope with the reality. You are told you have cancer? No, it's not me. And they are going to deny that. We need to appreciate that denial is like a wall of a stony building. You cannot see that patient. As they talk, they have denied, it's not me, I don't have cancer. So it is like a wall. So as a therapist, please don't take a hammer and start hitting that building. The whole building will come down. What you need to do is to try to look for a window, a small window, to penetrate through so that you can see the patient, so that you can manage and start bringing the denial down. The patient will continue. For some, denial is positive because some patients will deny, but they will continue with the treatment. That is good. So you don't need to keep on telling them, why are you refusing? You have cancer. No, just try to look for that small window. And then when they say, oh, I think I can start that chemotherapy, you can start from there. Did you hear the doctor, what he said? What is chemotherapy going to do with you? And then you start penetrating through. So you continue monitoring the patient, you continue supporting the patient, and one day you will accept this is cancer. The other difficulty is emotional reactions. Most of us, we are not comfortable to see patients cry, to see emotions, patients with a lot of emotions. And I want to appreciate that even in our local patients in our country, people mourn differently. When people are mourning, there are those who are throwing themselves on the floor. There are those who are not crying. There are those who are reacting like this. Are we able to pick that? Are we able to support them even at that particular point? The other difficulty is pollution, which is generally an act of love. This one I see very much in my clinic. Most of the time when they come to the hospital, you will see the relatives coming inside first. And you are like, where is the patient? The patient is outside. Can I help you? We were just coming to tell you, please don't tell our mommy has cancer. Because the moment she knows she has cancer, she will die. And she's going to die. So you will ask them, suppose your mommy comes inside here, and when we are talking about other issues like pain, she asks me, doctor or sister, because here, any woman who is working in the hospital is a sister, and any man who is working in the hospital is doctor. Sister, what am I ailing from? Will I cheat? At least we have ethical principles which guide us. I'm not trained to cheat. So I'll tell your mom, this is it. I know how to break bad news to your mom if she asks. But is it harmful to tell your mom that she has cancer? Is it going to benefit her, or is it going to harm her most? So you need to guide yourself. And then when we talk to them like that, they see, oh, there is sense. She can be told. And when the mama comes in, we are going to talk to her. And then when she asks, we are going to take her through the breaking of bad news. So I'm not going to talk about all the difficulties, but I've chosen to talk about breaking bad news as one of the difficulties, because I know that this is where most of the people get stuck. And what are bad news? By definition, breaking bad news is any information that drastically and negatively alters the patient's view of their life or their future, according to Bachman, 1984. And whose responsibility? It will depend with the setting. Some hospitals, it is the doctor who is supposed to break bad news. Some other facilities, it is the nurse, it is the palliative care nurse, it is the psychologist. Where I work, anyone who is comfortable, who is competent, can break bad news. So we are going to learn about the spikes protocol. In the year 2000, Walter Bell and colleagues from the US set up a 6-step protocol for breaking bad news using the acronym SPIKES. The S stands for setting up session, just getting starting. Are you set for that task? Because it is not easy. You need to be knowledgeable. You need to read the file and know, what am I talking about? I'm going to talk to a patient who has been diagnosed with hepatocellular carcinoma. So you need to know the facts about hepatocellular carcinoma. Deal with your own issues, because you don't go there, then you start crying with the patient because your sister or your brother had the same condition 2 months ago. You need to deal with yourself. Finish up the pressing work. In your office, you don't need to be going out and picking calls and all these. So you need to finish up with the pressing work. Then your phone should be silent. Environment should be arranged, privacy, adequate space, which has good lighting. And the patient comfort is key. Involve significant others. When you are breaking news, it is bad news, it is to have somebody with a patient for support system. It is helpful to start with a question like, how are you feeling today? To indicate that the patient that this conversation will be a two-way, we are going to discuss. Let the patient be aware of the nonverbal communication, both for the patient and yours. Remember, as you read their nonverbal, they are also reading yours. When things are bad, they are also seeing the doctor is also closing his eyes, is also being shaken. So be aware of that. P is for perception. And this is finding out how much the patient knows. Before you tell, ask. It is important to gauge the patient's understanding of their situation at that particular time. Don't just jump and say, I know this man knows everything. It is good to pose a question like, would you kindly share with me all what you've been told by your doctor about your condition, Mr. P? And the patient will start all back from this year and that year, and he will tell you, I've gone there, I've been done this, X-rays were done and this way, and I don't know anything else. This helps you to determine the capacity of the patient and if they are in denial. Remember, some patients can even take 2 years with the denial. They just decided not to accept in their mind that denial is there. I is for invitation. And this one is how much information is the patient willing to know. After sharing with the patient, after she has told you how much she knows, now it is your time to fill the gap. But you need to know, how much do you want to know? Don't overburden the patient with a lot of information. For instance, you can say, Some patients tell me to cover everything medical details to them, but other patients want only the big picture. What would you prefer yourself? This establishes that there is no right answer and that the different patients have different styles. So some patients will tell me, it is my disease. I want everything. I want everything. Others will say, just tell my sons, I don't want to know. I only want treatment. Others will say, I just want to know a small bit. I don't want a lot of information. So people are different. The key is the knowledge. And this is where now you share the information. But before you share the information, it's important for you to pause, then assess, present the information. Before you present the information, always give a warning shot. And what is a warning shot? A warning shot is that step you can give to a patient just to show that things are not okay. I'm about to get bad news, but that one prepares the patient to prepare for more worse. So present bad news, more junks, and stop in between to check that they understand. So after the warning shot, and an example of a warning shot is you can tell a patient, your report has come back and it's not good. And the patient will, huh? You check the patient. Yes, it's not good. You have lung cancer. Then you pause and you look how they are feeling. You observe. Then you continue if the patient is allowing more information to come. And again, I also want to tell you anything, sometimes we give bad news or we give good news thinking it is bad news to the patient. We can also give bad news thinking it is bad, but it is good to them. Did you hear that? What I mean here is, let me give an example so that it can explain well. There is a patient I was taking care of. This patient had a very big tumor on the thigh, very big, a lady around 40s. And she had been done a biopsy, and every time they took a biopsy, it is negative. 3 times. This particular time we had decided, let us take now to the good private pathology labs, which we know in Kenya, and we are like, okay, let's now wait. And the patient is like, I just want to know what is happening. Can you remove this leg? And then the report comes again, negative. So you are going to give the patient information, the report is negative. As is like, oh no. To you, the report is good, but to the patient, he wants to know it is cancer so that something can be done because he's tired of waiting for reports which are not coming out clearly and there's no treatment. So sometimes good news can be bad news. Use proper words as you tell the patient, it is cancer, not spots. Don't tell the patient on your x-ray, we saw some spots in the lungs, and not carcinoma, not adenocarcinoma. Repeat the information. Do not overburden the patient with a lot of information. If you tell the patient, studies have shown that when you break the news, most of the patients go on mute. They don't understand anything. They don't listen to anything else. So if they are not listening, don't go further to discuss about treatment options. So avoid the patient that disease is a lot. There is nothing we can do. Even if the disease has advanced to a curative treatment, patients should be reassured that support will be provided to improve their quality of life. At least we can control their pain as palliative care specialists. The E is emotions and the empathy. Respond to patients' feelings. If you don't understand patients' reactions, you will leave a lot of unfinished business with the patient, and you will miss an opportunity to be a caring expert. So unless you capture those emotions so that you can respond to them, that is the only way you can help the patient. So stop talking when they are crying, when they are throwing tantrums. Allow silence to take over or a pause. Observe and identify the reasons for their emotions. So phrases of emotion range from denial to fear. Others will say, now I'm going to die. Oh, anger, sadness, self-pity, depression, and all that. Explore and respond to them, and give patient uninterrupted time to express their emotions, and let them know that you are connecting to his feelings. This must be very difficult, Mr. P. I can imagine what you are going through. Don't tell them you understand, because you cannot understand. No one can really understand exactly what they are going through. You can only imagine. So remember also, you are not responsible of their emotions. You are only there as a messenger. You passed the information as a messenger, but you are not responsible of the of all this. It is cancer. It is the disease. So take care of yourself, ensure safety, take a deep breath and allow anger to wash over you. It will stop. Maintain silence if it is there. Just use communication enhancers. Just encourage the patient to continue if they are talking. I can imagine. Don't interrupt. Listen more. When the anger is dissipated, consciously respond to reflecting by reflecting back to what you heard about the major parts of anger. Remember reflection in our tool. When they were talking, they could be talking about, oh, now I have this cancer. My wedding was supposed to be in August. Now what am I going to do? He's angry because of the wedding, not even because of the disease. So pick those words. As they keep, when they are now settled, you can now go back to ask the patient, I heard you talk about your wedding in August. Can you share with me more about your wedding? And you pick from there. S is a strategy and summary, where you need to plan for follow-up, for follow-up care. Find out if the patient is ready for further discussion. Don't start talking about chemotherapy, radiotherapy. No. Could the patient be? Patient might not be ready. Outline a step-by-step, immediate and long-term plan. Explain and contract about the next. Should the patient have unrealistic expectations, it may be useful to ask them to summarize what they have had. And they will tell you, yeah, I heard you say I have cancer, and all that. This usually reviews whether they have any concerns, whether they have any fears, whether they are still, they have already been started being in denial. Offer your recommendations. Help the patient to identify support network. Sometimes the patients are so much weighed down until you are seeing like they cannot go home. If the patient is alone, just in case, don't let them go home alone. You can ask them, can I contact one of your family members? Yes, you can take my phone, call my husband, call my pastor. I need prayers, all those things. Ask if there are any questions or concerns before they leave. Arrange for an appointment and follow-up care. Document findings in the file for other people to see what you've discussed. It's also important to know that we also communicate effectively with the children or other ages. There are children you cannot talk about, tell that you have this, you have cancer. Some like 3 years old cannot understand all these things. So you talk to the parent, as demonstrated there. Others will understand by drawings, heart, and when you tell them, can you draw for us how you are feeling today? They will draw. We use this so much in psychology, and especially when you are counseling a child, they will draw somebody who is, they can even draw a coffin, and you are like, oh, what does this one mean? So drawing is one of them. There is also age appropriate. There's also this boy is around 8, 10 there. This one at least can understand, but don't overburden the child with a lot of information. Just knowing you are sick, there is you are sick and you have a disease we are calling cancer, but we are going to treat you. That is enough. The teenagers, these are now the gurus who want to know everything. By the time you go to break the bad news to them or to talk to them about their disease, they have already gone to Google. They have already searched all this information and they know exactly what you are talking about. And they throw a lot of questions. So you have to be very careful because you have to know, I'm talking to a 18-year-old, a 23-year-old. This is not like a 74-year-old man, or it's not like a child. So these ones want to know everything. And they'll be talking like they are talking of this disease like it is for another person, but it is theirs. What are some of the barriers of communication? I've divided them into physical barriers. Where you work, maybe there's a shortage of staff, where you are not able to talk so much. You are just brushing off so that you can finish the queue outside. Staff shortage. You have no time. You have other many tasks to deal with. Background noise. Where I am seated, there is a lot of noise. You are talking to patients and every time there are things which are passing by and you are like, oh my God, now what is happening? Poor lighting. Poor lighting in the sense that we've seen you are supposed to also to observe how the patients are feeling. Are you able to observe in darkness? And poor signage. You send a patient to go to the lab or to the X-ray and they are going to get lost and then they come without whatever you send them. And the following day you are asking, where is the design? Structures which are not clear. You go there and they have labeled their pathology lab, they have labeled all this. Lack of clarity in roles. You are the one who is in the office as the manager, you are the one who is seeing the patients. So when they come, they don't know who to find. They don't know who to take care of them. Attitude barrier, lack of motivation. Staff are working so hard, they are not motivated. Even as they take care of patients, they are feeling like, this work is too much. They are not motivated. They are not paid well. They don't get their salaries in good time. But some, they have attitude just because they don't want to change. When we use words, ubiquity of words sounding the same, but you mean different, that one can confuse a patient. Patient's barriers, cultural beliefs. I'm telling this patient, you need to do this, you need to take this medicine, it's going to finish your pain, but when they go home, they are going to be told, no, please don't take that medicine. It is going to make you feel more worse. Or don't take medicine. Men don't, in our African culture, men don't, they are not supposed to show pain. So as we talk to them, there is that barrier. Even when they come to us, they want to talk about pain, but now they should not talk about it because they are men, not aware of their right to information. They come to the hospital, but they don't know whether they have a right of asking, doctor, what am I suffering from? They don't know they have a right to information. Physiological barriers, individuals' personal discomfort due to ill health. They are too sick even to tell us how they are feeling. They are too old even to communicate. And you go there and to ask them, how are you feeling today? You have no time to listen to them. You have not played the 80-20 rule. Their hearing has also diminished. Poor vision, they cannot even see you. And speech difficulties. If they have mouth ulcers, they have oral cancers, they cannot talk. So you are just assuming they have this pain or you are assuming they are comfortable. It's only that they cannot tell you. Presentation of information is also another barrier. The fact that the information is presented by a clinician who lacks skills. You come to the ward and you are like, now, why are you doing all this? I said all these patients, and you are shouting to patients. Other information is presented too complex by using medical jargons. I cannot emphasize that more. And you are also doing it so fast. And another barrier in this aspect is when you have somebody who has a different accent. for example, where I work in my national hospital, we have people who come to train from other countries. So when they come to study in Kenya. So when they are taking care of patients, they are talking in their accent. Just to give a good example, and sorry for those people who are logged in from this country, they are from Nigeria, and we are talking very, very fast. And your patients are used to talking slowly. So the patient will come back to sister and say, sister, please, I did not hear anything with that doctor. Please explain to me. And you are not with the patient. Some other communication barriers which has been posed by the COVID-19 pandemic. During the COVID-19 pandemic, I think this is familiar to everybody worldwide, and this brought a lot of distancing from us with our patients. We could not, there was social distances, one, there was gowning, and the patients also having masks. So that connecting with the patient was not easy, and the communication was not effective. We tried, but it was not like when we are seeing, when you can go closer to the patient, when you can apply touch, when you can talk closely, when you can lean forward to the patient so that they can see you are listening. So it posed as a big, big challenge as well. So as I conclude, good communication is good healthcare, and all people, even not just in palliative care, in healthcare, should embrace good and effective communication. Thank you very much. I'm going to invite my co-presenter just to give her input. Thank you very much for listening.
Thank you,
so
Gladys.
much.
Yeah, Mackuline, I think we'll head on to a few of the questions if that's okay.
Before you go, I just question.
So I'm just going to facilitate the questions. Gladys, I think you deserve a big round of applause for promoting good communication in palliative care. That was a really inspiring session today. And I'm going to share some questions with you and Mackuline. If you guys are able to answer, you can give Mackuline the chance, or you can answer yourself. But there's a few really good questions in the chat, and then we're going to move on to our case presentation. So the question here from Oswald is, so again, Mackuline or Gladys, maybe Mackuline, if you want to answer this one. What is the best way to shorten the longevity of denial following being diagnosed with a life-threatening condition? Are there things we can do to shorten the denial experience?
I think I can respond to that. As I say, the denial is like a wall of a stony building. There is no best way to deal with the denial. There is no, you cannot say you are going to deal with this patient for 2 months so that they can come from denial. There are those who go 2 years in denial. There are those who remain in denial forever. There are those whom you are going to meet the first day they deny, and they are going to say the following day, sister, now I'm okay. I think I'm ready for everything. So I said it is like a wall, a stone wall. So if you take a hammer and start hitting that wall, the whole building will come down. And when I say building here, I mean the patient will come down. The patient will die. If you force the patient to know about them, he's going to die. So what I'm saying is, what the best thing is just to support that patient. Encourage the family also to come over and talk to them so that they can also be a support system. And with good support, I've seen they usually overcome it. It is not easy, even you to be told you have cancer. Today, you will just collapse. Or to be told your wife has been involved in a road accident, and then the first thing you say is, oh no. So you can deny even the day, until the day you see her going to the grave. So there is no best way of doing it. The best way is to support, over support, and it will depend on how supportive you are. If you are not very effective, you can involve a psychologist. Thank you.
Thank you, Gladys. There's another question. I'm going to go through these questions kind of quickly because they're really good, and we want to get as much of your knowledge as possible. How do you break bad news to young children that are age 3 to 8? So I guess primary age or preschool. It's often a difficult task. So any advice?
Breaking bad news.
Yeah, to children.
To children. It is age appropriate. It should be age appropriate.
Yeah.
When we are discussing anything with the children, consider their age and consider also their developmental stages. Because the way you are going to talk to somebody who is 7 years is not the same way you will talk to somebody who is 2 years.
Yeah.
So as I said in my slides, some children will understand by drawing.
Mm-hmm.
Others will understand by being told this is cancer, but you don't go into details that cancer, it kills, it does what, no. Just tell them you have this condition, but it is manageable. Be a supporter more than telling the information. So it is age related, age appropriate. That is the word.
And there's an interesting comment here from Mohammed. If you tell the patient they have lung cancer, they will fall into emotional, psychological distress. So I think the question is getting at what do we do when patients get extremely emotional or distressed when we're sharing news with them?
Yeah, if you tell a patient you have cancer, not just lung cancer, they will definitely be emotional.
Mm-hmm.
And that is why I said that is one of the difficulties in communication, because as a palliative care specialist, you are supposed to be ready for those emotions, for those reactions. And there is no way, there is no best way of breaking bad news, even to tell somebody your mother has died.
Mm-hmm.
There is no best way. The only best way is how to support from there.
Yeah. Just continue to walk with them and journey with them, schedule follow-up visits. Yeah.
Yes. So you continue to work with them. You continue to support them because you've already told them you have lung cancer. And the patient will go on the floor, will cry. Just let them cry. Ensure safety in that room. Ensure they are okay. Ensure your safety also. Your safety becomes number one. And then they will cry, they will cry, they will cry. Later, they will stop crying. Then you will sit them up and tell them there is hope. There is treatment. We are going to be your support. We are not going to abandon you. The one thing patients fear is after you tell them like that, you will not be there anymore. They have seen you are very supportive and you are going to disappear. Reassure them you will be checking on them, you'll be there for them, and you will also work with them in this journey.
Yeah, really good points. Just a reminder, there's quite a few faculty on the call and there's lots of questions in the chat. So I think we're not going to be able to get to them all today. So if any of the faculty can begin to answer some of these questions, I'll just let someone has raised their hand. This will be the last question for our question and answer time. Palliative Akijabe, did you want to unmute and direct a question towards Gladys?
Yes, this is Pity. Thank you for the great presentation. My question would be directed to communicating to children who are of below 18 years. They can be able to understand their diagnosis and also their prognosis, but we get situations where parents literally refuse to allow us to communicate the diagnosis to these children, especially these children who really understand their diagnosis. What is the best approach towards that, with the understanding that these children respect to autonomy, and also the child to understand how the pain is, managing the psychological pain of the children, especially below the teenage age? That's my question. Thank you.
Good question. One, it's good to find out about their fears. The parents who are saying, don't tell our child that he has cancer. What are their fears? Maybe they think when the son or the daughter is told about cancer, is going to collapse and die. But you need to reassure them that there is a way you do it in a more professional way. They think you are just going to do like the way doctors, let me say that in quotes, they are going to say, you know, you have cancer and you are going to cut this leg. You are going to do it in a more professional way. After finding out their fears, now go to the ethical principles. Remember, is it good for your son to know he has cancer? If I don't tell them like that, they will see this condition, or they will hear it from other people. They will even go to your bedroom and get these reports and read, this is sarcoma. And then they will Google in their phones, hey, this is cancer. And they will hit them on the head. Mommy, you mean I have cancer and you have not told me? So encourage them. It is important for the boy to know that he has cancer through being taken through process of breaking bad news, the way we've learned here, in a systematic manner. And you are going to support them. So I said, that is what I was saying, it is collusion. Are you able to collude with them so that you can cheat your patient? Your patient here is the son. So you want to collude with the mother to cheat the boy? No, we need to support the family together with the patient. And that is the goal of palliative care.
Thank you.
Thank you, Gladys. We're going to switch modes now to go into our case presentation time. There's so many questions, so we'll probably have to follow up with some of these answers on our WhatsApp chat, but that's okay. I think this is a really important topic. I will try to go through the case presentation fairly quickly so we can have even 10 minutes in small group to discuss with everyone how we're doing. So let me share my screen, and I'm going to now present to you the case on communication. So today, the main concerns that we're going to discuss are how to communicate with parents when a child's condition has relapsed. So this goes towards quite a few of the questions that came in on the chat, and the last one from Kijabe. And then how to address a child's concern when the child doesn't understand the diagnosis and prognosis of their illness. So I want to introduce you to a 6-year-old young girl. She had an enucleation of her right eye several months ago at another hospital, and the family was advised for chemotherapy at the time, but they couldn't afford to travel to the capital city to access the treatment. They presented in the ED with evidence of the tumor progressing into the right orbit, abdominal swelling, and the child was severely malnourished. She had a limitation in the opening of her mouth with foul breath and difficulty swallowing. So at the time, upon assessment, there was a query whether it was a retinoblastoma versus a neuroblastoma. The mother and father were there with the child at the visit. The father has 2 older daughters, aged 18 and 12. The father was a farmer and the mother was a housewife. The parents had recently sold their land and spent all their money to get the surgery for this young girl. And they previously were told by the surgeon that she was cured of her disease. The little girl had studied up into 1st grade, but then she stopped going to school 1 year back after she was diagnosed. She didn't know much about her illness, but she was aware that she had a tumor or a mass. She was concerned about her parents because they were really worried, and most of the time they were crying. She got really anxious whenever she saw her parents cry, and she felt better when she was playing with her friends. So from a palliative care perspective, we know that this is an advanced cancer for this child, and therefore there wasn't a chance for a cure for her disease. This news, like we were talking about today with Gladys in the presentation, needs to be provided to the family in a compassionate way. So if you can take a minute to think about these questions and put them on the chat, how will you tell them the news? Identify a few of the steps that you think you would go through before you saw them. And then review the way that you would discuss the results with them and the rest of the family. We can take a little bit of time to answer these on the chat. So just put a few thoughts, type a few thoughts out, or if you have your notebook and pen, you can write them in your own notebook. Think about what you would do and how would you tell them the news? So with the spikes model, we talked a little bit about setting the environment. Yeah, using the spikes method, we would want to set up the area. Being an emergency room or casualty, often it's extremely busy and loud. So if this is where you were seeing the patient and the diagnosis and prognosis was shared with the patient at that time, you may want to find a quiet area, possibly in another area of the hospital. So perfect. So what we would do when we want to share difficult or bad news with families, we need to make sure we do the spikes model. This is a good way for us to remember. We set up the conversation. We identify the perceptions of the patient and the family. We invite them to know more about the situation. We share the knowledge or the information we want to clearly relay to the family and patient. We identify their emotions and then we summarize. Yeah, really good. We need to make sure we have an area for the family and the child and make sure you have lots of time so you're not interrupted. Really good. So when we think about setup, what are the most important things to consider for this family? And the perception is, what words would you use? So I think we identified a few of those. Some ideas for this situation is make sure you have a private room or a quiet area. You could invite a team of counselors or the psychologist or whoever's on the healthcare team that you think would be helpful to have in this meeting. Of course, with a child, when they have a relapse of their cancer, it can be very, very difficult and emotional. And if you do have a palliative care team, then you would want to invite them to that meeting. When we try to identify patients' perceptions, we could use examples such as, what have the doctors told you about your daughter's condition? And you would want to use specifically the child's name. What do you understand of why your daughter is sick? This helps us understand, what does the family know about what's going on? Really good answers in the chat. I think all those are really helpful. I like the idea, I wish I had better news, but that's coming up next when we talk about a warning shot, where you give them time, where you say, I'm about to share some difficult news. When we begin to invite a family into a situation and we share the actual details of the diagnosis or their prognosis or a change in their medical situation, these are some examples of what we could do. So as we invite patients and families into these kinds of discussions, we ask them, can you tell more about what is happening? And then as we impart the knowledge of what we know about their situation, we can use examples such as, unfortunately, I have bad news to share. Very clearly, we say the tumor in your daughter's eye has come back after the surgery. And lastly, this is cancer and it cannot be fixed with medicine. We need to be very clear when we share information and we allow patients and families to to ask any questions they may have. So again, like Gladys was saying, you need to make sure you pause throughout these conversations and allow the family to listen and hear what you're saying, and also ask any questions that they have. If you have any other good examples of how we could do this, you can put them in the chat as well. As we move on to the E and the S of the spikes model, we focus on emotions and providing empathy to the family and the patient. And then we end with summarizing. So how do we acknowledge the emotions of our patients and families? And what are the steps that we would suggest to, this family, not man, the daughter and their family, about the ways to move forward? For a 6-year-old, there is a chance that she would be able to be involved in the conversation depending on how mature she is as a 6-year-old. And again, that will be decided with the medical team and the family on how much to include her in the conversation. I think that would be on a case-by-case basis. Again, when Gladys is saying using coloring and age-appropriate ways to communicate with children regarding their disease is really, really important, not excluding them completely from these conversations. So one way to show emotion and empathy towards a situation is by simply stating, I wish the situation was different. I think for many of our patients, this is true. And we could all agree that we wish that many of our patients were not in the situations that they were. Other empathetic responses could be naming the emotion. I can see that you're feeling very angry, or I can see that you're feeling very sad. We want to understand. For example, I expect most people would feel that way in your situation. We want to respect their response to their illness. You have shown remarkable courage. We could say this not only to the patient themselves, but we can also say this to their parents or their siblings. We need to remind them that we are here to support them. So we could say very clearly, we will support you through this. Gladys mentioned earlier about sometimes patients feel abandoned. This is something in palliative care that we really focus on, not abandoning our patients, even at the end of life. And the last one is to show an empathetic response. Sometimes we ask the patient to explore their emotions further. So we could say, tell me more about how you are feeling. Explain to me what you're feeling right now. And these are ways to identify more about how things are going for them. And finally, as we summarize, we need to make sure we check for overall understanding. Do you have any more questions for me at this time? Do you have any more questions for the nurses or the doctors or someone else on the medical team? At this point, you do want to review a plan for the next steps of the treatment or supportive care that you would be offering them. And it's really important that we document that the discussion happened in your file or your chart, so that others on the team know that you have disclosed new information to the patient and their family. So back to our case, the parents were made aware about the prognosis of the little girl, and they were having a lot of difficulty accepting that there were no more treatment options available to cure the child's illness. And this is very common in many of our situations. So multiple counseling sessions had to occur. So when you break bad news, we sometimes think it's one conversation and done, but it doesn't work that way. We need to continue, and we need to identify that there is a chance we would have to make multiple counseling sessions or multiple times of discussion with the family. When we communicate with children, we use drawings and toys. And in this case, drawings and toys were used by the psychologists on the team to help the child better understand their concerns, and they began to address a few of them. She now understood the nature of her disease and why she required repeated blood transfusion. So she was beginning to understand more through age-directed communication. Several weeks later, the parents were in acceptance after those repeated counseling sessions. And the palliative care team understood the child's concerns through using art therapy and toys. The psychologist shared with the parents that actually their crying and their outward emotion of sadness made their child specifically very upset. So together they decided that they were going to try to limit their child's exposure to their crying to help with her well-being specifically. And that's the end of our case. As you can see, when we communicate and when we share these difficult situations with our patients and families, it's not easy. And it does require a lot of work and a lot of focus as a team. I haven't specifically been following the chat, but I think we will try. There still are a few faculty members on the call. I think we're going to try to move into some breakout rooms so we can have smaller discussions about either this case or specifically how you do when you communicate difficult news. So in your breakout room, I will start the breakout room shortly. Looks like we have actually maybe 20 minutes, so we still have a bit of time. So we will head into those breakout rooms and I will share the questions, but today the breakout room is specifically to talk about your experience of sharing bad news in your setting, things that are easy with sharing bad news or things that are challenging, and then work together just to support one another. If there's some things that are challenging, you can kind of give advice to one another. So that's the way our breakout rooms will be structured for today. Let me just make sure that they are organized still. I think we're going to have four rooms today. Okay, so Dr. Megan, you're going to be in one room. The next room is Anne. Are you able to stay for a breakout room?
Yes.
Okay.
Sorry, I'm
perfect. So
having
Anne,
something wrong with. Yeah, I'm good.
video.
I can stay.
Okay. Okay, so Anne, you'll be in room 2. Mackuline, you'll be room 3. And I'll head to room 4. So we'll start the breakout rooms now, and then we can just come back together in about, maybe 15 minutes. Thanks, everyone. Eli, you need to turn that on.
يا هذا انت ممكن ليش ما هم لازم كل ابوان كاركا ها markay ku soo daadanayaan dad waxa jira ma garan markay ku soo daataan already dadan inta dadka sheekada saan oo kale waxa ku soo dhacaan qofka markuu kaligiis socday markuu meel fadhiyo markaas ku soo daadan
Hey everyone, I'm so sorry we went a bit over today. Sorry about that. Thanks for hanging on with us. There's not really many announcements, just we are on again for next week. And I will upload the session and the presentations really shortly. I think we can say a huge thank you to Gladys. I think she's not on the call anymore, but thank you, Gladys, so much. And I think we'll definitely be calling you back to be a speaker in the future. Thank you to Mackuline as well, and Vicky, and all the faculty members who were able to facilitate the breakout rooms. I don't know if we have time, but Dr. Megan, did you want to share anything from your breakout room? We're going quite over, but.
We just talked about how to talk to children, and I just shared a few links for
great.
a website called Kids Grief, and it's also available in French, des Enfants. And I shared a workbook on the WhatsApp that's like for children. And you don't have to give them the whole workbook, but look at some of the pages, because it shares like one thing kids need to do is think about how does my body feel when I'm sad or when I'm worried? And like they don't recognize that the feelings, like their heart beating or feeling, whatever they're feeling is because of how their emotions are. So teaching children to recognize the body feelings and how it relates to emotions is very useful and very therapeutic. So that there's some pages in the book on that, and it's like just gives you some ideas of how to talk to children.
Well, that's really good. Thank you for sharing. Mackuline, did you want to just share a brief 1-minute synopsis of your group or how it went?
Yes, thank you. In our group, we shared our experiences and the challenges that we have at our workplaces in communicating. And some of the key things that came up was the first one was for children, that after seeing a child in a palliative care unit and they are referred to another facility, they find it hard to come back because some of them pursue active curative options. And then also after breaking bad news, there was the issue of follow-up. What do we do after that, after breaking bad news? And what we promised that we'll look for a sample distress protocol and share with the team so that they can adapt in their sites after breaking bad news. How do they follow up, or how do they react to the reaction after for the people whom they are broken bad news? And then also the issue of being cultural competency, being aware of the culture at hand and what some of the words and what some of the actions, the meanings might come up. Thank you.
Oh, really good. The other faculty was Anne. She had to just jump off the call. So I think we'll probably end there. Thanks so much for staying on extra time today. We will be again back on Tuesday, same time. The topic for next week is a really important one. Again, we're talking about supporting patients with psychological distress, specifically using a trauma-informed approach. So we hope you can join. And thanks everyone. I'll upload the recording and the resources this week. Have a good one. We'll see you next week. Bye everyone.
Thanks so much and bye.
Thank you. Bye. Good evening.
Bye. Thank you very much.
Bye.